this is a more difficult decision in children and young people than it is in older adults, and we've all known that. And I think it is important that people do it properly and do it according to the normal ways, as MHRA have, JCVI have, and we have. So yes, it's about doing it thoroughly, and I think we've now done a pretty thorough look at multiple aspects of this. Natasha Clark, The Sun.
Are you confident that this will help prevent schools from shutting again in the winter? Have you looked at any modelling in relation to that? And secondly, now that obviously kids as young as 12 are going to get the jab, is that the lowest you'll be looking at the age range for children, or should we expect you to look in future at whether kids under 12 will get the jab? And also, are you worried that this will get in the way of booster jabs for older people as we go through with that this winter?
Thank you. So in no particular order, we do not think this is going to interfere with the booster jabs for older people. We have plenty of vaccine stock for the relevant vaccines for these, and they're being deployed by different mechanisms. One is through a school mechanism and one's more widely. So I do not think that we're concerned about that. In terms of are we confident about reducing disruption, the answer is we are confident about reducing disruption. We are also confident this will not eliminate disruption. And that is very much central to the way we want to present this information. Because it reduces the chance a child will get COVID, if they had, probably by about 50–55%, and it will reduce the chances that a child who then gets COVID will pass it on. We expect it will reduce the number of outbreaks in schools as well as a direct effect on children. So it would be very surprising if it did not reduce and probably reduce to a significant extent the amount of disruption in schools if many children take this up. But we definitely do not think, this is back to a point that Professor Lim made, we definitely do not think that this alone is going to be the thing that deals with educational issues. And it's really important that policies are kept in place that minimise, or at least policies are not put in place that increase the risk that further disruption will occur. So I think it is pretty critical that we actually keep those in balance. But our view is that overall we do expect it to reduce but not eliminate. Under 12, we certainly have no plans at the moment to re-examine this. There are some nations that are doing this. It hasn't even got to the point where this has been considered by MHRA, so we're a long way even thinking about this. So I think let's not rush that one at all. Hugo Guy, The Eye.
Professor Whitty and Dr. Smith, you both talked about how this decision was taken solely on the basis of the impact on children aged 12 to 15, not a broader societal impact. But do you expect this decision will anyway have a broader societal impact? And if so, have you done any modelling on what that might be?
Gregor, since this was addressed to us jointly.
Thanks, Chris. We've confined our review at this point in time of considering only the evidence and the benefits in relation to 12 to 15-year-olds. That's a really important point of principle in terms of how we've gone about conducting this aspect of it. However, we know from experience of other vaccination programmes that by reducing transmission across age groups, that it may have a beneficial impact across those age ranges. But I would emphasise again, those were not part of the considerations, deliberations, or even part of the discussion that we had in presenting this advice to ministers at this point in time. And I'm not aware of any modelling that I've seen at all which suggests what impact this would have on those older age groups, particularly because we confined this thought process, this discussion solely on the benefits to the 12 to 15-year-old age range.
Yeah, I just add that, I mean, there are academic groups that have looked at this. It's not that this is an unknown question, but we have not taken that into account at all because we very clearly wanted this to be just benefits and risks specifically in this age group. In general, though, anybody who has a vaccine is protecting people around them as well as themselves, and it goes in every direction. So old adults being vaccinated will reduce the risk to children. Probably the same is going to be true the other way, but we have not looked at any modelling on this. I don't think there are any other questions. We've got two people who put their hands up. Can I just take those as the final two because we all have to also get on and do some various other things. But I am keen also that people do have the opportunity to ask questions. This is an important issue, which is the reason we're here, really.
Thank you. Tom Harwood, GB News. I noticed that earlier you said that rushing didn't feel like the right thing to do. But surely throughout this whole pandemic, it really has been the right thing to do. And other countries that have been faster than us, whether it's lockdown or anything else, have seemed to have had a bit of a better experience. And the one thing that we were faster than the rest of the world on was vaccines, and that's where we really soared. So was it really the right thing to do, to wait so much longer than other countries, to wait until after schools had returned to do this? Because it's going to take a long time to roll these out and for these to be set in. And won't the benefit be less now that schools are already back than if we had started when America had started?
Well, I think I think trying to compare national differences is actually more complicated, and it's sometimes made out. Sometimes we've been ahead in terms of our advice, sometimes we've taken a bit more time, and that's true for every nation. So I'd just be very cautious about trying to over-interpret differences. But I would go back to our general view. It is important that we follow the normal processes we would, and we take the time it takes to get the information we need. And I think anybody who believes that the big risk of COVID is now it's all in the past and actually it's too late to be making a difference, has not understood where we're going to head as we go into autumn and winter, where there will continue to be challenges, there will continue to be pressure on the NHS, and there will, for the purposes of this debate, importantly, continue to be disruption to education from COVID. So I think it is important, to say at this point, our advice is there's a universal offer, because we think for the coming terms and for the longer term, we think this is going to reduce educational impacts as well as have reduced impacts elsewhere. But we're in danger of repeating ourselves. We really want to take this decision seriously. We've taken it seriously, and we've got a unanimous view from the Chief Medical Officers. Last question.
Thank you, Professor. Ben Kentish, LBC. Lots of parents will listen to this wondering what say they will have in helping to decide whether or not their children get vaccinated. Could you just say a little bit more about consent and on a practical issue, assuming ministers do adopt your recommendation, when you would expect this vaccination programme to start? And if I could just ask Professor...
I'm going to stop you there, because we also have other things, but can I answer those two? And then if you're really dissatisfied, we can do the third one. But the first one is a really difficult question to explain, but actually it's a relatively straightforward answer. So the decision about who provides consent for children between 12 and 16 was laid down in law by the law lords who were just before the Supreme Court back in the mid-80s. There was a landmark case. All the law lords came to a very, very clear decision about how consent should be considered. That can't be overruled by doctors. It can't be overruled by ministers unless they go through Parliament and change the law. That is the law. And what that does, essentially, is it says above a certain age there's an assumption that people will take their own decisions, and once you're 18 you have to, and below a certain age there's a high assumption that children cannot take decisions, and then there is a period between those when, depending on what the decision is, the child's views may be more important, or child or young people's views, and as they get closer and closer to the point that we get to the top end of that age range, an assumption they can actually understand the issues involved, and therefore they can start to be involved in a decision. Now, in the great majority of cases, and I'll turn to Gregor as a recent GP on this, in the great majority of cases, children and their parents come to the same decision. So it's an irrelevant question, actually. For a small number of cases, there is some debate around this, and doctors, GPs, paediatricians, people involved in vaccination programs are really used to doing this. Remember, this ruling about what the law says was laid down in the mid-80s. We've been doing exactly the same approach to this since the mid-80s. Whether a GP, a paediatrician, or anyone else dealing with children and young people, this approach is completely standard. And so I think, and people are very used to it, and they're not really, most doctors don't find this particularly tricky. So, I want to reassure people we're not doing anything different in this than would be done for any other medical situation where consent was involved in people over this age range. Gregor, I would like to turn to you, really, as someone who's done this as a GP.
Thanks, Chris. I mean, I've found myself involved in discussions like this on many occasions as I've sat down with children, their parents or their guardians, and we've discussed exactly the nature of the benefit and the approach that can be taken with various interventions, whether that be medicines, whether that be vaccinations or operations. And the important thing is to be able to have that discussion. I agree with you, Chris, when you say that by and large, you find that there is a great deal of agreement between children and their parents in relation to how to proceed. But the important thing is to be able to set that out and assess whether those children either have the competency to act for themselves. It's very similar in Scotland, as you've just described, in England and Wales. Following that ruling, this is almost the bread and butter of the approach that GPs and other clinicians who've been dealing with children and young people for many, many years have taken in any aspect of consent that they take on a day-to-day basis.
Yeah, and I would just add, I mean, I would not underestimate the ability of children and young people to understand important issues that affect them directly. I think it's easy to do so. You had a second question, which I allowed, and then after that I said I was going to draw the line.
Very briefly, Professor Liam, when you talked about the marginal health benefit of vaccinating children, I just wanted to ask about that because the JCVI data suggested if you vaccinate 1 million children, you'd prevent 87 hospitalisations, and between 3 and 17 children would get myocarditis, almost all of which would be resolved in a short time. Given those figures, could you just briefly say a little bit about how marginal that really is? Because it seems like quite a significant benefit.
I think it's very difficult when you're just looking at numbers to try and weigh them up and say one hospitalization is equal to one case of myocarditis, because we are talking about different reasons for being hospitalized and different longer-term consequences between these two situations. Similarly, if you're looking at admissions to intensive care unit or other benefits, if you will. So it's not a straight case of just doing the maths and adding up the numbers and knowing which one is high and which one is lower. There's much more to those numbers and to that table. We did spend many, many hours looking at the whole range of benefits, and that table is simply there to show what the background numbers are, but each of those numbers have to be weighed up to determine what the severity of illness is and what the consequences might be. So I would just warn against just adding up numbers and saying which one comes out higher than the other.
Thanks, Shen. So thank you all very much indeed for taking the time and look forward to seeing you again in person. It's been very nice to see you all. And thanks, as always, to my colleagues in Scotland, Wales and Northern Ireland. Thanks a lot.